women go through female genital mutilation, and there are several kinds of classifications for it. As a plastic surgeon, these are two questions. Why is reconstructive surgery not as loud and as open as it is for, let's say, other plastic procedures that could be done? That is one. And secondly, how do we handle this kind of women who have gone through such mutilation?
The women in the community would be the ones protecting the girls from undergoing FGM. But a lot of stories I've heard were it's the women in the community who are perpetrating the genital mutilation in the sense, to occur, in the sense that it was the mothers and the aunties and, all these women in the community who are pushing the agenda or taking their girls for these kind of procedures. I know one lady who even refused her children to meet her parents. Even at death, she refused to take them to the funeral of her parents. So her children never met the parents because she was always afraid that if they ever met the parents, that they would also be made, she had two girls, that they would also be made to undergo. In this Kenya, a very large growing population of the LGBTQ community. And there are patients who, or let me say this particular patient was male and wanted to transition to be female. So, the research, they found the list of doctors that they needed to see, went and saw the urologist, and the urologist was like, okay. Because, sometimes when doctors don't know what to do, they just pass the problem to the next doctor.
Another one, yes.
So the urologist passed the problem on to, the plastic surgeon. And there's another guy who came more recently. This was a male. Male patients, you have to be a little bit more careful because they can really be problematic, and wanted some of the most outrageous things I've ever heard of in my life. And I told them, look,
thank you for being there. To the Laughing Lab Coat family, thank you for being there. Thank you for engaging. Thank you for sharing. Keep subscribing, keep commenting, keep engaging with us. To those who haven't, kindly do so. We noticed we are about 70% have not subscribed. Lowering that number down helps us build a sense of community as we go forward. Today's guest is a board-certified plastic surgeon, Dr. J.P. Ogalo, also known as Dr. Rekebisha. Daktari, karibu.
Asante sana. Happy to be here.
I've been
watching you guys from afar.
Yeah, it's nice.
I was happy when I got the call. I was like, I made it.
Thank you, Doc. And when it comes to plastics, first thing on the mind is tummy tucks, facelifts, boob implants, BBLs, and majority of the people who have such body images desire that outcome.
Yeah.
How do you handle patients who desire this Kardashian effect?
Kardashian effect, man. That's okay. Let's run with it. The Kardashian effect. I'm not sure it's the best benchmark, but okay.
Okay.
The Kardashian effect, because I have a lot to say about the Kardashian effect, but probably another time. Patients are all very different, and the one thing that I've come to know and come to understand is that you need to take them for who they are and understand their journey to the point where they've gotten to you wanting that tummy tuck or that BBL. All right. So the first thing is always to kind of never judge them, and more to lean in and kind of understand and, listen to them and for them to tell you why they got there. Because once you realize the story behind how they got there, then it becomes a lot more easier for you to treat and to understand without necessarily labeling them a certain way.
Okay.
So you need to treat them very delicately because they're very delicate patients. Delicate from a more emotional and psychological aspect. And what they're coming to us do, is to give them an outcome that, for example, is in their head. And my only job is to deliver that safely, right? It is not to cast judgment on, why they want a certain thing, but it's like to tell them, sit them down and tell them, okay, this is what you want. And this is what I realistically can do, what I can realistically achieve. And this is the potential risks of you going into this particular thing. And, with that information, then we can go ahead, and I would do my best to deliver this service to you in the safest possible way. Yeah.
Among them, you've mentioned the psyche part.
Yeah.
So you majorly look at their past history, maybe medication, stuff like that.
Mm-hmm.
Are there those who you tell straight ahead, I don't think a cosmetic surgery would work for you. You go home, do this and this and this.
Mm-hmm.
Do you find such cases?
Yeah, a lot. So I'll give a very typical example. A lot of patients will come into the office wanting liposuction, right? Or tummy tuck. But when you start looking at the motivations or the intentions behind it, this patient actually wants to lose weight. All right. And then I have to pause them and slow them down and listen, look, okay, you might want liposuction or a tummy tuck, but you need to understand that those are not weight loss procedures. If your goal is to lose weight, there are different ways you lose weight. Okay. You just start talking about calorie deficit. You start talking about bariatric surgery, exercise, gym, diet, all these other aspects. So, there are patients that I do turn away and tell them, look, that thing that you want is not the right solution for you. You need to look in a different direction and, kind of walk them through that process. Yeah. And then at the end of that process, then if they're still interested in the tummy tuck and the liposuction, then yes, come and do it, provided they understand what it is that I'm giving them at the end of the day. And we completely have to be aligned and on the same page in terms of what it is that I'm doing for them. Yeah.
At what point do you look at a patient and sema mini patient nimekukujia, I'm like, I've tried weight loss, I've tried diet, I've tried so many things, this is the last option that could work for me. How do you get them to think of the mindset that yes, the surgery might work, but and how or what should I do so that I don't get back to where I was? How do you handle them?
Okay, so I have a process in my office. All right, when the patient comes, like I tell you, I'm usually very invested in the story behind where they're coming from and why they're here. So of course, you do your whole, thorough investigation and blah, blah, blah. Then I educate them. I take a lot of time to educate them. My office, I have a big whiteboard that's there. So I tell them, okay, sasa, after examination, kila kitu, nakachini, I'll tell them, okay, now let's do class. And I start, this is your diagnosis. This is the procedure that we're going to do. All right. This is what the entire procedure entails. These are the risks, blah, 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 everything, so that they completely understand it. And I'll tell them exactly why I think that this is the right procedure for them or this is not the right procedure for them. Now, if the patient insists on a procedure that I do not feel is the correct one for them, then I wash my hands and tell them, look, I don't think I'm the right doctor for you. Maybe you can try somewhere else. But it is important. I realize I've never gotten to a point where I'm stuck with a patient, or very rarely do I get to that point where I tell them to go look for somebody else. But once you've educated them and they've understood what it is that you're telling, they're usually very appreciative of it. And you don't kind of end up to a point where a patient is really pushing and insisting that they want something that's not right for them. Yeah, that's a patient you'd have to say, okay, maybe you need a little bit of an evaluation from somebody who can evaluate you on a psychological level.
Have you seen some of them who, like, you told them, I've washed my hands.
Yeah.
I don't want to do this procedure for you.
Yeah.
And then they go ahead, do the procedure somewhere, get complications and stuff, alafu wanakukujia.
Okay. I've had 2 patients, all right, like that. In my most recent memory, I've had 2 patients like that. I don't know how much I'm supposed to say or allowed to say on camera. But one, in my opinion, was very troubled lady, very difficult to deal with, had come from actually somewhere else, had multiple procedures done on her. In fairness, the manner in which the procedures were done on her were not, in my own mind, the right way in which they should have been done, or rather, like, there was stuff that was done that she didn't consent to, and
She didn't consent to.
she didn't consent to, and obviously, when you do things that somebody didn't consent to, they'll obviously end up hating it, right? So that was one lady. So when she came to me, she said, okay, this and this place, they did A, B, C, D. I didn't like it. I want this. All right. And she came with very, very unrealistic expectations. And I told her, no, sorry, I'm the wrong doctor for you. There's another guy who came more recently. This was a male. Male patients, you have to be a little bit more careful because they can really be problematic. And wanted some of the most outrageous things I've ever heard of in my life. And I told them, yeah, look, that thing that you want, I can't give it to you.
Just a question.
Yeah.
Was this like something related to the male sex organ?
No.
Okay.
No, it wasn't. It wasn't. That one you can find a justification to do it, provided the person understands what they're getting themselves into. But it's very difficult to reduce the size of somebody's head.
Okay.
Yeah.
Oh, okay.
I mean, where do you start? And the person is convinced that this can actually be done. Yeah.
And I'm sure that, I think, when do you tell them you're chasing a false dream, watch out? Like, let them get it into their minds. At what point do you tell them, yo, you're chasing a false dream? Stop. No, Bialini.
I probably would. I don't usually tell them that they are chasing a false dream. You kind of have to finesse and package it in a nicer way. But essentially, what I'd be telling them is this result that you want doesn't tick my box for what is realistic, and I personally can't give you this outcome that you desire. I physically can't. So, and if I do it, you're going to end up, pissed off at me, and you're not going to like your result, and you'll have wasted your money. Yeah. Because I also try as much as possible not to, you need to be very careful, especially in the medical field and especially in cosmetic surgery, about your reputation and protect it at all costs. Doesn't matter the cost. Okay. So if somebody is throwing, 1 million shillings in your face, you really have to ask yourself whether that 1 million shillings is worth it in the long term. Because some of these things can really backfire on you, and you end up in the long term in a very, very difficult, tough place that you don't want to be in. Yeah, it's good to say no. I'm sure you've been told in med school, the best surgeons know when not to operate.
When not to operate.
Yeah, and that thing stands true. And man, I mean, you'll come to learn that, know when not to operate. Sometimes it's just not worth it. Yeah.
What is the most treasured moment as a plastic surgeon that you have?
That is a tough one. It's a tough one because, I mean, for me, even just being in theater on any given day, I find it so satisfying. The outcomes, the challenges, the problem solving and all these things. But I mean, at least for me, the most satisfying work comes a lot from reconstructive surgery. When you have a kid, 35% burns, face, chest, torso, arms, all these things. You see them from the day they come in, right? With a face you can barely recognize, their eyes completely shut, closed, their mouth swollen, the mother crying, the father blaming everyone, and, all these issues. And then seeing them 5-6 weeks down the line, smiling in your office, so those are some of the good moments. It's very, very simple things, and then you can see the gratitude in the parents' eyes. It's not probably the most glamorous of stuff, the most glamorous of surgeries, but there's as a doctor, you can never deny that satisfaction that just comes with getting somebody from a place where they're literally, if you think about it, some of the lowest points in their lives. All right, not just physically, but mentally as well, and taking them to a point where they are healed, or at least better, and they can actually look back and say, yo, what the hell did I go through? And thank you so much for holding my hand throughout that journey. Another doctor was telling me recently how, as a doctor, it doesn't matter what's going on, all right? It doesn't matter what noise is happening, compensation, salaries, all these kind of things, you being pulled in different directions. You can never, ever separate being a doctor from that will and ability to serve, right? That is literally the center or the core or the foundation of it all. Yes, you need to get paid and compensated. Do not get me wrong. That's not what I'm saying. But you cannot remove service from all that. Yeah. And that's where you really find the pot of gold.
Are there any dilemmas you have come across as a practicing plastic surgeon?
So we live in a very interesting and changing world. Unfortunately, I can't speak on one of the dilemmas I was in recently because it's too recent. However, there was a dilemma that was brought, to me by a colleague. And, they were essentially getting my opinion on whether they should operate on the patient. So we have in this Kenya a very large growing population of the LGBTQ community. And there are patients who, or let me say this particular patient was male and wanted to transition to be
female.
So, the research, they found the list of doctors that they needed to see, went and saw the urologist, and the urologist was like, okay. Because, sometimes when doctors don't know what to do, they just pass the problem to the next doctor.
Another one, yes.
So the urologist passed the problem on to, the plastic surgeon, and plastic surgeon came and asked me what I thought about the situation. Because for them, morally, I'm talking about the confluence of their religious beliefs, their own cultural beliefs, and their own beliefs as, a human being, that confluence of all that stuff, they were not comfortable with it. And I was having the discussion with them because, my opinion is, slightly different. And, as much as the cultural and religious foundations of who we are as people is there and needs to be respected and needs to be understood, and I have no problem with anybody who stands on what their culture and religion tells them. Where does that then meet who you are as a professional and the job that you are put here to do, or the job that you chose to do? Because this patient is coming to you with a need, all right? Whether you agree with the need or not, let's call it inconsequential for now. Can you, to the best of your abilities, deliver a safe outcome for this patient, given that you're the only person who has this particular skill? Was kind of where the conversation went. And for me, at that point in time, and I'll say that point in time because our opinions tend to change over time, and it's okay for them to change. My feeling was that, look, you have the skill to do this thing. Get it done. Or else where will they go?
Give me a follow-up question.
Yeah.
There is a documentary shot by Matt Walsh in the US where he noted that children were being brainwashed in the sense that they're now being made to think of transitioning their sex from either male to female or female to male. So some of these kids would be given GnRH, and it will either kill off the male sexual characteristics that the child will have to feminize them, or the opposite side. Do you think it will happen in Kenya at some point?
Have you lived in Kenya? I feel like anything can happen in this country. You see, my problem with that is that, you see, gender is about socialization, all right? And whatever gender you choose to be, follow all that stuff. In this situation, it sounds more like somebody is literally engineering it, because you're intervening with something that is hormonal, that is external. You're influencing the outcome of what this person will believe to be their gender or their sex in time. And for me, that is tricky. Yeah. You get my point. It's not. You're giving somebody a drug to make them a certain kind of way.
That makes sense. Talking about reconstruction and gender. We personally, for me, and I speak for majority of the people from my community and majority of the northeastern side, where our women go through female genital mutilation, and there are several kinds of classifications for it. As a plastic surgeon, these are two questions. Why is reconstructive surgery not as loud and as open as it is for, let's say, other plastic procedures that could be done? That is one. And secondly, how do we handle this kind of women who have gone through such mutilation as a plastic surgeon again?
Okay, so why isn't it as loud? I think the context behind how FGM comes about and how it is perceived in society is very critical to answering that bit of the question, because it's traditionally always been hidden or shamed, and there's a certain kind of stigma towards it, and that also affects how much noise is made about it later on down the line, because a lot of women live silently and secretly with this, and getting them to come out is very difficult. And even when they do come out, how many of them are willing to kind of tell their story or to push it out there? And it's also not, to be very honest, glamorous. Even by the name itself, you're saying mutilation. Nobody is necessarily proud about mutilation and wants to shout it at the top of the hills. What we do try as much as possible to shout at the top of the hills is the fact that there is some hope in the rehabilitation of these women. But generally a lot of them don't like necessarily talking about it. The ones I've seen, or even the ones that I've treated, even their closest friends or even some of their family members would have no idea.
So it will be a hidden kind of procedure with the patient and her consent.
Yes. I've even come across patients, even their own fathers don't know what happened. Because, and this is what I found very, very interesting when it came to FGM, because you would think that the women in the community would be the ones protecting the girls from undergoing FGM. But a lot of stories I've heard were it's the women in the community who are perpetrating the genital mutilation in the sense, to occur, in the sense that it was the mothers and the aunties and, all these women in the community who are pushing the agenda or taking their girls for these kind of procedures. And in some cases, like this one patient I was telling you, the father even had no idea. Whether he was telling the truth is another story. But I found that very, very interesting. Yeah.
How do we cut that? How do we cut this women who are the perpetrators for this gender mutilation? How do we solve that?
It will take a very long time. It is something that is so inculcated and bred into the traditions, and traditions to, I don't want to say, let me say the uninformed can really sway opinion or how things are done within the community, because you see, once you've undergone the painful process of having undergone, for example, FGM, and you've healed and everything, you to an extent kind of block it out, and that was in the past, and to some extent you find some women saying, oh, it wasn't that bad, plus they've been
kind
raised,
of repression.
Yeah, there's some kind of repression. And then you've also been raised to believe that, okay, now I've undergone this thing, now I'm able to stand in the community at a certain status. All right, it's elevated your status within the community, and you find everybody else has undergone it. So, okay, this must be the normal thing to do. So the next generation, you do the same thing, but it takes somebody within that community or within that family to say that, no, this is not going to happen anymore. And that's the beauty of a lot of the education we have coming up. The women are more and more informed. The women are talking, they're speaking. They know that they can get the rehabilitation, they can get the reconstruction, they can get the therapy, which is an extremely also important part of it, because that then breaks the cycle of it going to the next generation. But again, if you look at it, it is also a very small population of the larger whole that has undergone this enlightening, all right, which is great. It's a starting point. But will it get to the point where it's the entire community that has shifted the thinking? I hope so. Someday.
Okay. And there's a friend of mine, a very dear friend of mine, who runs an NGO.
Yeah.
And at some point we were seated discussing, and she asked me to try and formulate some kind of report or request to send to one of the donors to see if we'll be able to get like a camp going for FGM reconstructive surgery. And we never spoke since, but the one thing I noted from that occurrence is that very few people were aware of the reconstructive bit being there.
Yeah.
Who do we blame?
I don't think it's useful to blame. All right. The question we should be asking is, how do we fix it? Okay. Now we're in a good place. All right. Because as I was saying earlier, you have a lot more practitioners in place who are able to offer the service of, FGM reconstruction, which perhaps, 20, 25 years ago, there weren't that many. Okay. And now we do have more people. So we are building capacity. The capacity has been built. Now, there are very many elements that go into rehabilitating a woman who has undergone FGM. The organizations that I have worked with or have made an attempt to work with, because it doesn't always go the way you think it would go, look at the different elements. So one is, where are these women? Okay. So ask yourself where these women are involves rescuing them. Okay. So there are organizations that rescue women who have undergone FGM. Okay. Because sometimes these women, they either escape or they want to be escaped, or they know somebody who has undergone FGM. So they bring all of them together and they have a database. Okay. Now, once you have them together, the next step is now, how do you actually go around the rehabilitation? Because it's very difficult to jump straight to the surgery. There has to be something in between. There has to be a clinical element of, one, is this woman okay? All right.
Mentally.
Is she mentally and is she physically okay? So the mental part is extremely important. Okay. So you need to kind of attach them with a therapist, psychologist, or psychiatrist to find out how, they've dealt with the trauma, because it's very difficult, again, to do reconstruction on somebody who is still who is still working through the trauma of what they underwent, or has repressed it. Okay, because you can end up with very unsatisfactory results. Okay, so there's the rescue, then there's the rehabilitation, which now includes the psychological aspects and the physical aspects, and then the surgery comes later. The surgery is never a hurry. Okay, the surgery can always be done, and then thereafter you still have to have continuous follow-ups with the psychologist in terms of trying to help them work out. So that kind of tends to be the framework of doing so. And then because I'll tell you, man, these a lot of these ladies have so many different stories. Some of them ran away from their communities, never to go back. I know one lady who even refused her children to meet her parents, even at death. She refused to take them to the funeral of her parents. So her children never met the parents because she was always afraid that if they ever met the parents, that they would also be made, she had two girls, that they would also be made to undergo FGM.
So that phobia is always there.
Yeah, because sometimes what happens is that the grandparents, okay, you as a parent might have said, okay, this is not happening to my girls, but the grandparents are like, no, this is happening, this is tradition. So even without you knowing, they take your girls or your children and
subject them to
and subject them to the female genital mutilation without any of your knowledge, right? So that's what happens in some of these communities.
Oh.
Yeah.
And I'm mind blown by that. I think I've only seen a few while practicing, and that usually happens when they're in labor suit, where they're about to deliver. That is when you actually get to experience, okay, this one, kuza normal. You just advocate for maybe a CS if there are any other expounding things that would trigger that decision to be made.
Yeah.
It's sad.
There are some who even had it done so young that they don't even know that there's a problem until they get to now that point where, it's a cesarean section or they're coming in for examination. They actually have patients who it has been pointed out to them by the partner with whom they're intimate in. And they're like, okay, this is not kind of the anatomy that I'm used to. Maybe you need to have it checked out. And they come and, you tell them, okay, this has happened. And some of them may have no memory of it, whatsoever. Or they blocked it out, or they'll tell you, oh yeah, I remember this one time we did something, but I don't know what that was. Yeah, so there are very many heartbreaking stories out there of a lot of how these things go down. And
what can we do better as doctors?
Awareness. We need to push that a little bit more. It's a collaborative effort because, again, doing the FGM care is not free. It's not cheap either. It's also not something that, to the best of my knowledge, has been picked up by government or the authorities.
Ushaisikia kampeni yoyote ya serikali nasema eti leo we're going to educate certain communities on why FGM is?
There are. I believe there are some that have happened, but I'm not just sure how heavily it is funded or pushed because, again, there may also not be a very good understanding of the scale of the problem. Yeah.
Interesting.
Yeah. I know there are local studies that have the data, but there's a lot more we can do to shout about it. Even on our side, the people who actually do the reconstructions, in partnership with people who do the therapy and all these things, and the NGOs.
Yeah, it kind of needs a multidisciplinary approach from doctors, plastics, uro, to maybe a psychiatrist, psychotherapist.
Correct. It needs a voice. Yeah.
I'll drift you a little bit away from the topic of FGM.
Yeah.
When someone thinks plastics, the first thing that comes into their mind is, apart from the procedures, is chums, dough. Why is it expensive?
Is it expensive, or do you think it is expensive?
Majority of the people do think it's expensive.
All right. How much do you think it costs to get liposuction done?
On average, I think 300K plus.
300K plus. All right. How much do you think it costs to remove an appendix?
About less than 300. 150 to 300.
I would challenge you that they cost me around about the same thing.
Okay.
Again, depending on where you go and who's doing it. Okay. So you have to kind of separate perception from what the actual reality is. Now, if we're looking at the cost of cosmetic procedures here in Kenya, it is vastly different from the cost of cosmetic surgeries in the West. Now, if you're looking at it from the angle of, because there's a way, even the way you've asked the question, it sounds like you're saying, it just sounds like you're thinking, it's just liposuction. Why should it cost so much money? All right. As opposed to the thinking that, oh, this is actually a surgical procedure that requires some level of skill and some level of inputs that are very professional and that have taken a lot of time and to accumulate the knowledge to be able to do so. Right? So you have to factor it in that this is an actual surgical procedure that should cost a certain amount of money. Right? So here I'm talking about everything that's used in theater, the time that is used in theater, the expertise of the person who is actually doing it, okay, and the equipment that's used to actually do it. Because, if I'm doing a liposuction, I've had to buy a liposuction machine because they're not just in theater, right? There's a cost to that. There's a cost to the maintenance of it, okay? And even when you look at liposuction, I'm just using it as an example. There are many things that go into the care of the liposuction patient. All right, you need your fahas, you need your garments to be worn afterwards. You need your massages to be done by a nurse every single day thereafter.
Post-operatively.
Right? Post-operatively, and those, come at a cost. So there's that. Okay, and there's also the fact that we live in a capitalist society. Okay. And the laws of business cannot be separated from medicine, right? So if the laws of economy state that if there's high demand, then what happens to the price?
It spikes.
It spikes. When the demand is low, it goes down.
Let's talk average numbers.
Yeah.
Say I want a BBL or a boob job. Average cost in Kenya, how much would it be?
You're going to get me in trouble. Okay. So, a BBL, in my opinion, okay, because we also live in a situation where people will undercharge, okay, just so that they can have a competitive edge. In my opinion, a BBL shouldn't cost you anything lower than 700,000 shillings.
So 700 plus.
700 plus, all right? And there are people who would charge in the millions, all right, for that same procedure. So I'll give a broad range, all right? And this is not my pricing. I'm just
disclaimer.
Yes, I'm talking about the industry and how it's currently placed. So a BBL in a decent hospital, very important, by a decent surgeon doing a decent job, with the aftercare and everything that it entails, you're looking at anywhere between 700 to, let's say, probably 1.5 million. Yeah.
Oh. So wale wanahitaji, they should budget for that amount.
They should budget for that amount, yeah.
I have a question.
Yeah.
At what point do you tell this person, this BBL that you desire is not realistic? And that, assuming someone is skinny, like mifupa, and they want, let's say, Vera Sidika kind of ass.
Yeah. You tell them that at the first consultation. You tell them, like, yeah, no, this can't work for you. Yeah. So, you have to figure out other options. Yeah. So you end up using fillers and, things like that. Yeah. But also back to the cost, all right, and the pricing, and why you're saying that cosmetic procedures are expensive.
Costly, yeah.
Anytime there's a price attached to anything, okay, you have to ask yourself, as the person buying it, buying the service or the product, and as the person selling it, is what value is there in it, okay, and how valuable is this to the person who is
Getting the product or service.
who is getting the product or service. So there are kind of like two spectrums to how you can look at value. All right. So on the higher spectrum, it's the person who is buying the service. In this case, the patient, right? So what does this liposuction, what does this BBL mean to the patient? Now, if it means to the patient that for the next whatever period after this, I will be more comfortable in the way I look. I'll be able to wear any dress that I want to wear. I will be able to walk into a room and feel more confident about myself. I will be able to go into a dating pool very confidently and, pull the kind of attention or the kind of person that I want to fit into my life. That is valuable. All right. That is very valuable to a lot of people. Okay. Because it touches on so many aspects of your life. Okay. And then the other end of it is the person who is providing this service is, what is the lowest cost that they're willing to provide this service at? Okay. Knowing fully well what value they're providing to you. And, as much as possible, the charges are fair. Okay. Because there's also a lot of unseen things that, that let me say transpire, that happen with patients who are coming in for cosmetic surgery that you may not see. Okay. Before you're able to convert that patient who requires a cosmetic procedure, all right? By conversion, I mean they've come to your office and you've convinced them that they're coming to this. There are very many steps that are in between. Okay. So one, you have to have convinced them that you're the best person for this procedure, so that you're talking about your expertise, your skills, and all your training. And then you're talking about also how you've branded and marketed.
Does litigation play a role in the cost?
Absolutely it does. All right. And then you have to also think that, pulling in this patient, getting them to my office, I've spent X amount of money. And then you're trying to also create a fantastic customer experience for them. That is also expensive. So there are also very many hidden costs that go into these cosmetic patients, getting them through the door. Because if you look at the reconstructive patients, they bring themselves. The cosmetic patients don't necessarily do the same. You understand? Yeah. So
if someone clicked on this podcast now,
yeah,
what is the first thing you think they should have picked from here?
The first thing they should have picked from here. I would say one is being able to kind of understand the stories and the cultures behind the patients that we see, and not treating them like they are a single one-dimensional entity. Okay, so to understand where they're coming from and why they're coming and what it is that they want from you on a very human level. It, in my own opinion, allows you to practice a lot more ethically and to be able to give your patients the outcomes that they desire. All right. And also, it'll save you a lot of problems down the line if your patients simply just like you. All right. The other thing that probably is also important is being able to understand the question that you asked me about pricing and cost and value. All right. For doctors to be able to understand what value they're putting into the market and how to price that value. And not just how to price the value, is to show the patients that value. Okay. Because being able to price one thing, I can say, I'll do your skin graft for 1,000,000 shillings. Okay. But how do I convince you that this skin graft I'm doing for you is worth 1 million shillings?
Oh, nice.
And those are the things they don't teach you in med school, how to fill in that gap. Yep.
We've come to the end of it. Any final message you'd want to say to the medical students, doctors out there?
One is to you guys specifically. I love what you're doing with this platform.
Thank you.
Yeah, I've seen it from afar, and I always love it when people are doing fun things in the space, because medicine can be quite boring sometimes. To the medical students, you guys, man, hang in there. It's not all that bad, even when it's bad. And even when things are bad, sometimes they're only just for a season. We still need you guys to come through. Get mentors, please get mentors. Don't think you know everything. It'll get better. To the medical doctors, know your worth.
Know your worth. Umesikia. Solidarity. Anyways, we've come to the end of it. To those who have been watching and not subscribed, do that. The more you subscribe, the bigger we get, the more we scale production, the more we bring in more ideas and all that. So check out our pages, social media, YouTube, everything. Yes. Also, big thing, Dr. J.P. Ogalo
At Rekebisha.
On TikTok.
On Instagram, Rekebisha. On TikTok, I think it's JP Ogalo. Most of that one's just JP Ogalo. You'll find me.
Your face? Or kutafute DM.